Welcome to the Funnel Effect. Today we are doing a really monumental deep dive. We're looking at the 2025 American Heart Association guidelines for CPR and emergency cardiovascular care. I mean, these guidelines, they're pretty much the global standard for saving lives. And this update, it's massive, just packed with critical changes across, everything. We're focusing on the executive summary of this huge piece of work. And we really have to start by acknowledging the people behind it, the principal authors and contributors. It's quite a list. Ready? Marina Del Rios, Jason A. Bartos, Ashish R. Panchal, Diane L. Atkins, Jose G. Cabañas, Bajik Howe, Katie N. Dainty, Cameron Desfoulian, Aaron J. Donahue, Ian R. Drennan, Jonathan Elmer, Karen G. Hirsch, Ahmed H. Idris, Benny L. Joyner, Bina D. Kamathrain, Monica E. Kleinman, Michael C. Kurtz, Javier J. Losa, Henry C. Lee, Mary E. McBride, Tia T. Raymond, John C. Rittenberger, Stephen M. Schexnader, Edgardo Sild, Alexis Topshian, Jane G. Wigginton, and Jeanette K. Praviti. Wow, that's a lot of brain power. It really tells you how important this document is. So our mission today, think of us as your shortcut. We're not just going to skim the surface. We're cutting through all the complexity to pull out the most significant stuff. The really high impact changes from these new guidelines, everything from, basic bystander stuff to advanced post-arrest care. And crucially, the why. Why did they make these changes?
Exactly. And when you look at the sheer size of this update, you see the core philosophy. These 2025 guidelines, they're intensely focused on two things: really measurable goals, boosting overall survival rates, and improving neurological outcomes after cardiac arrest. That's key. It signals this shift, towards a more integrated, holistic approach. High-quality CPR, absolutely. Early defibrillation, yes. But also, and maybe most importantly, creating this seamless system of care, one that follows the patient right from the moment they collapse, through the hospital stay, and even into recovery. It's a whole system rethink.
Okay, let's unpack this. So to really get a handle on these changes, maybe we should look back a bit. Like, where did these guidelines even come from? I know this started way back, right? 1966?
That's right, 1966. It started because people were asking for standards, but the way they're updated now, it's fundamentally different. We're not stuck in that old 5-year cycle anymore.
Okay, so what does that mean for the actual science we're talking about today? Does it make it more current?
Oh, absolutely. It means the science is incredibly fresh, super responsive. These guidelines work very closely with ILCR, that's the International Liaison Committee on Resuscitation. And back in 2015, ILCR made this big switch. They moved to what they call a continuous evidence evaluation process. So instead of waiting years for some big update, they can do focused reviews almost immediately when strong new evidence pops up.
So things can change faster if the research supports it.
Exactly. Scientific breakthroughs, whether it's about, say, drug timing or how fast to ventilate, they can move from the journals to the bedside much, much faster. It also explains why the guidelines themselves have kind of grown since 2020. They've added whole new chapters.
Yeah.
Big sections focused on that continuum of care, post-cardiac arrest, special situations, even ethics. It's not just a what to do right now manual anymore. It's more like a guide for the entire resuscitation wall.
Right, and all this new information, this continuously updated stuff, it's organized somehow. We keep hearing about this Utstein formula for survival. What is that exactly? Why is it so important?
The Utstein formula. Yeah, it's basically the foundation, the philosophy behind the whole 2025 structure. It helps us move past thinking that survival is just about luck or, just having good CPR technique. Think of it like an equation for survival. It says survival depends on three things, three factors all working together. Interacting. Factor 1. Guideline quality. That's the solid science, the evidence we're digging into today. Factor 2. Efficient education. Making sure everyone from a top cardiologist down to like a panicked family member gets trained properly and efficiently. And factor 3, often the trickiest one, is well-functioning local implementation. Basically, having good systems of care that actually work on the ground. In your specific town or hospital, if any one of those three is weak, survival rates drop a lot.
That makes total sense. I mean, the best guideline in the world doesn't help if the ambulance takes too long or nobody nearby knows CPR. But let's talk about why this is also urgent. The statistics, they're pretty stark, aren't they? Cardiac arrest is still a huge killer. Every little improvement matters.
It really underscores the ongoing crisis. If you look at recent U.S. data from 2024 CARES data, out-of-hospital cardiac arrest, OHCA, happens to about 378 people per 100,000. That's a lot. And despite everything we know, survival to actually leaving the hospital, still incredibly low. For adult OHCA, it's only 10.5%.
Well, 10.5%? Wow.
Yeah. Now, in-hospital cardiac arrest, IHCA, it's better, 23.6%. But that just shows the advantage of having doctors and nurses right there instantly.
Okay, but here's where it gets really interesting, right? The bystander part. That seems like where the biggest potential gain is. The stats there are kind of shocking.
They really are. So if someone witnessed the arrest and started CPR, survival to discharge was 13.0%. Compare that to unwitnessed arrests, only 7.6% survival. That's a huge difference.
13% versus 7.6, okay?
But here's the kicker. Only 41.7% of people who had an OHCA actually got CPR from a bystander. Less than half.
Less than half, so more than 50% of people just
Yeah.
didn't get that basic first step.
Exactly. And when you realize that, you see why these new guidelines are pushing so hard on public policy, on education. That gap,
Yeah.
that represents tens of thousands of lives we could potentially save.
So the science needs to be great, the professionals need to be sharp, but getting the public involved, that's maybe the biggest lever we have.
That's the clear mandate. We need to optimize everything, but empowering and, importantly, activating the lay rescuer community. That's where the greatest system-wide improvement can come from.
Okay, so optimizing the system. First thing, it looks like they simplified the main visual, the chain of survival. I remember in 2020, there were like 4 different chains: adult, peds, in-hospital, out-of-hospital. Seemed a bit complicated.
It was definitely complex. And yeah, the 2025 guidelines streamlined that significantly. They took those 4 chains and merged them into one single, unified 6-link chain of survival.
Just one chain now.
One main chain. The idea was to, cut down on redundancy, make things work better together across different settings. Whether it's a kid or an adult, hospital or home, the core steps are now presented in a more harmonized way.
Makes sense. What about prevention? Is that in the chain?
That's interesting you asked. They actually talked about adding prevention as a 7th link. They know it's important. But they decided it needs a bit more work first, like defining it clearly, figuring out how to measure it before putting it formally in the main chain. But they're aiming to get it in there eventually.
Okay. But I saw there is a brand new chain. For newborns, that sounds like it touches on prevention.
Yes, absolutely. This is a really important addition. Neonatal resuscitation is just different. It's often something you can anticipate. And it depends heavily on what happens before the actual arrest. So this new 7-link newborn chain of care, it reflects that wider context. It starts way earlier with prenatal and intrapartum care. That's the prevention piece right there.
Yeah.
Then it goes through the usual resuscitation steps: stabilization, recovery. But critically, it also includes structured follow-up care, really focusing on optimizing things for both the baby and the parents, especially in those first crucial 28 days.
Mm-hmm.
It recognizes that the baby's outcome is tied to supporting the whole family.
That feels like a much more holistic view. Okay, beyond the chains, they also cleaned up some of the language, right? Getting rid of terms that might be confusing or, I don't know, passive.
Correct. Standardization is key for clear training. There are 3 main language shifts to notice. First, the term lay rescuer. They really prefer this now over layperson or bystander.
Lay rescuer. Why the change?
It might sound small, but it's psychologically important. Lay rescuer implies action. It gives that person, the non-healthcare professional, a clear, active role. Bystander, on the other hand, kind of suggests just watching, maybe hesitating.
Ah, okay. Encouraging action. What else?
Second, they clarified breaths versus ventilations. The term rescue breaths is basically out. If someone has a pulse but isn't breathing, or you're breathing for them during CPR, you give breaths.
Just breaths.
Just breaths. The word ventilations is now specifically reserved for healthcare professionals using a device like a bag mask or an advanced airway. It clears up who's doing what, basically.
Got it. Layperson gives breaths, professional ventilates with a device, and the third one.
The third is a bit more nuanced but important for research: ROSC versus ROC. ROSC is return of spontaneous circulation. That's when the heart starts back up on its own. ROC is return of circulation that's used when circulation is achieved using mechanical means, specifically eCPR, ECMO during CPR.
Why does that distinction matter so much?
It's all about data clarity, really. If you lump mechanically assisted circulation into studies looking at spontaneous return, you skew the results. You might overestimate how effective standard CPR protocols are on their own. So separating them helps keep the research clean, especially in those advanced trials.
Okay, that makes sense for the research side. Now, here's where it gets really interesting. You mentioned this earlier. The guidelines are directly tackling health equity. This seems like a major focus.
It is a huge focus, and it ties right into the AHA's bigger 2030 impact goals. They recognize that having the best science doesn't mean anything if it doesn't reach everyone, everywhere.
And the data shows it's not reaching everyone equally, right?
Sadly, no. The data is, frankly, a call to action. The latest AHA statistics updates show these persistent, really unacceptable inequities. Survival rates, neurological recovery after cardiac arrest. They're significantly worse for people from minoritized racial and ethnic groups, specifically Hispanic, Black, and Asian individuals, compared to non-Hispanic white individuals.
How much worse are we talking?
The numbers are pretty stark. Favorable neurological outcomes. 34.4% for white people, but only 21.7% for people from minoritized groups. That's not just a small difference. It points to a systemic issue.
What's driving that huge gap? Is it just about hospital quality?
It's complex, definitely. But the guidelines point strongly towards socioeconomic factors and, crucially, unequal access right at the start of the chain. Lay rescuers, CPR, and AED use. Communities with lower socioeconomic status or certain minority groups often just don't have the same opportunities for training. Maybe it's cost, maybe it's geography, not having classes nearby, or even language barriers for the training materials.
And geography itself plays a role too, like rural versus urban.
A big role. The data shows your odds of surviving an OHCA are roughly 50% lower if you live in a rural area compared to a major city. 50%.
Wow.
So the guidelines are explicit about this. Implementing these 2025 changes must prioritize making things equitable and accessible. They're treating these disparities almost like a design flaw in the system that needs to be fixed, especially when resources are limited.
All right, let's dive into the practical changes now. The BLS stuff that impacts everyone from lay rescuers to pros, starting with systems of care prevention first, especially for in-hospital cardiac arrest.
Absolutely. Preventing IHCA is always the best strategy. So the guidelines reaffirm the strong recommendations we already had for things like early warning systems and rapid response teams. Those are proven to catch patients who are deteriorating before they arrest. But there's a key new recommendation here: using safety huddles for patients identified as high risk. This gets a strong COR 2A rating.
Safety huddles, what does that involve?
Think of it as a quick, focused meeting. The care team gets together, maybe at the start of a shift, and they specifically identify, say, the 3 or 4 patients on that unit who are most likely to have problems, maybe arrest, in the next few hours. It's pretty simple, procedurally, but it forces that team focus onto the highest risk individuals. It can be really protective.
Okay. Makes sense for the hospital. What about out in the community? It looks like there's a big push on policy changes to get lay rescuers to act more often.
Yes, this is huge and directly driven by the opioid epidemic. There's now a very strong Class 1 recommendation, meaning the evidence is overwhelming. It's basically mandated for public policies, allowing people to use naloxone for a suspected opioid overdose without worrying about getting into legal trouble.
Removing that fear of prosecution.
Exactly. It takes away a major barrier, both legal and psychological, that might stop a lay rescuer from stepping in and potentially saving a life during an overdose.
And they're still pushing for community mobilization through other means too, like tech.
Definitely. It's a whole package approach. Promoting community education, big mass media campaigns, continuing the push for mandatory CPR certification in schools or workplaces. That's a COR2B, still valuable. And yeah, really leveraging mobile tech. Things like dispatcher-link apps that can alert nearby rescuers. And for the dispatchers, the telecommunicators themselves, the instruction to immediately tell callers how to do compression-only CPR for adult OHCA. That's been bumped up to Class 1, the highest level. The evidence is just so strong that it's effective and, crucially, makes it way more likely someone will actually start CPR.
Okay, compression only for adults is strongly emphasized for lay rescuers. But now pediatric BLS. This seems to be where things differ quite a bit, especially on the compression only front. Why is giving breath so much more critical for kids?
This is a really vital distinction, especially for lay rescuers. For adults, arrests are usually cardiac first. The heart stops. So compressions are paramount. But kids, most pediatric arrests start with breathing problems. They stop breathing, become hypoxic, then the heart stops. So getting oxygen in, giving those breaths, is often the most critical thing you can do.
So the science backs that up.
Oh, yeah. Big observational studies in children clearly show the best outcomes happen with conventional CPR. That means chest compressions and breaths. It's a Class 1 recommendation, superior to compression only in kids.
But compression only is still better than doing nothing at all.
Absolutely. That's a COR 2A recommendation. If for some reason breaths aren't possible, just do the compressions. But the primary message for kids has to be conventional CPR, compressions, and breaths is best.
Got it. And what about the actual technique for compressions on infants? I heard one method is basically out now.
That's right, the old 2-finger compression technique. It's officially eliminated for infants. Reviews just kept showing it often didn't get deep enough, didn't meet the required compression depth consistently, it just wasn't effective enough.
So what's the recommended technique now?
The preferred, and now Class 1 recommended method, is the two-thumb encircling hands technique, where you wrap your hands around the baby's chest and use both thumbs. Especially if you have two rescuers, this method gives much better depth and consistency.
Okay, two thumbs good, two fingers out for infants. What about choking? Foreign body airway obstruction, or FBAO, has that changed for kids?
Yes, and it's actually been standardized now to align better with the adult recommendations, which helps simplify training. For severe choking in a child, you now start with cycles of 5 back blows, followed by 5 abdominal thrusts. Repeat that cycle until the object comes out or the child becomes unresponsive.
Back blows first, then thrusts.
Right. The thinking is that back blows give a good initial shot at clearing the airway.
And that same change applies to adult BLS for choking, too.
Exactly the same. For a conscious adult who's clearly choking severely, you start with 5 back blows, then move to 5 abdominal thrusts. And again, the second they become unresponsive, whether the object is out or not, you immediately start CPR. Compressions become the priority.
Okay, good to have that consistency. And even, like, how you kneel to do CPR got an update. Little details matter, huh?
They do, especially for maintaining quality over time. There's a subtle point now recommending that rescuers try to align their knee with the patient's torso when they're kneeling beside them.
Why does that help?
It just improves your body mechanics, give you a better angle, a better vector for the force you're applying, helps you maintain good depth and rate for longer without fatiguing as quickly.
Makes sense. And we saw a lot of patients positioned prone, face down, during COVID. What do the guidelines say about doing CPR if someone is already in that position? Do you have to flip them?
So the standard is still supine, face up. That's ideal. But the guidelines now say it's reasonable, CR2B, to consider doing CPR in the prone position if turning the patient supine isn't possible or would cause a significant delay, like a life-threatening delay in starting compressions.
So if someone's trapped, or maybe in the middle of surgery?
Exactly. Don't waste precious seconds trying to turn them. If it's difficult or dangerous, just start compressions. Typically, in prone CPR, you'd compress over the thoracic spine, sort of between the shoulder blades, to get that pressure through to the heart.
Okay. Lastly, for BLS, let's talk tech. Mechanical CPR devices versus those feedback pads. What's the verdict?
Yeah, this is a really interesting contrast. For the mechanical CPR devices, the machines that do the compressions for you. Routine use is not recommended. That's a Class 3. No benefit ruling.
No benefit, really.
A routine use, yes. Study after study shows they aren't generally better than good, high-quality manual CPR in terms of survival outcomes.
Okay, so the machines aren't the answer for everyone. What about the feedback devices, the ones that tell the human how they're doing?
Now that's different. Routine use of real-time feedback devices, the things that give you prompts like push harder or push faster or good recoil, those are recommended. COR2A. The evidence shows they significantly improve the quality of manual CPR, the depth, the rate, the recoil.
So technology is best used to help the human do better, not necessarily replace the human.
Precisely. Unless there are specific situations like CPR during transport in an ambulance, or maybe for rescue or safety in certain environments where mechanical devices might have a role that's a CR2B consideration. But for general use, high-quality manual CPR enhanced by feedback is the way to go.
Okay, moving into the advanced stuff, ALS. These changes seem focused on shaving off seconds, maximizing impact during those really critical moments. Let's start with PALS, pediatrics, and the big drug, epinephrine. What's the news there?
The big shift for epi and PALS is timing. Getting it in earlier is key, really, to boost that coronary perfusion pressure as soon as possible. So, for non-shockable rhythms like PEA or a systole, where electricity isn't the first answer, it's now reasonable, COR2A, to give epinephrine as early as you can. Don't wait.
And for shockable rhythms, VF or pulseless VT?
There, the priority is still defibrillation first. But it's now reasonable, COR2B, to give the epinephrine after the second shock attempt fails, or maybe even sooner if getting the defibrillator ready is taking time. The overall message is, for both non-shockable and shock-refractory rhythms in kids, get that epi in faster than we perhaps used to emphasize.
Okay, faster epi. And for kids already in the ICU with invasive monitoring, there's some really specific physiological targets now.
Yeah, this is getting quite sophisticated. If a child already has an arterial line in place, meaning you can continuously measure their blood pressure invasively, healthcare teams should now use the diastolic blood pressure, the DBP, to gauge how well the resuscitation is working.
Diastolic pressure, why that specifically?
Because DBP is our best easily measurable proxy for coronary perfusion pressure, how much blood is actually getting to the heart muscle itself during CPR. And they've even set targets, It's reasonable, CRR2B, to aim for a DBP of at least 25 millimeters of mercury in infants and at least 30 in children 1 year or older. If you could hit those numbers during CPR, you know you're likely perfusing the heart adequately. It shifts things from just following a clock to actually guiding therapy based on physiology.
Very cool. Okay, switching to adult ALS. Let's talk about cardioversion for unstable AFib or flutter. Sounds like a pretty big change in how that's approached.
It is a major procedural shift. Previously, the approach for unstable atrial fibrillation or flutter was often incremental. Start with a lower energy shock, maybe 50 or 100 joules, and then go up if it didn't work. The 2025 guidelines now recommend, COR2B, that for urgent electrical cardioversion in these unstable patients, you should start right at 200 joules with a biphasic defibrillator.
Start high. Why the change?
The evidence suggests that starting higher gives you a much better chance of converting the rhythm successfully on the first try. It shortens the time the patient spends being unstable, and importantly, it might even reduce the risk of accidentally triggering VF, which can sometimes happen with lower energy shocks. It's about getting the job done quickly and effectively when someone's unstable.
Makes sense. Get it right the first time if you can. What about polymorphic VT, that really irregular fast rhythm?
Right, polymorphic ventricular tachycardia.
Yeah.
It's inherently unstable, often degenerates quickly into ventricular fibrillation. So the guideline is now crystal clear. All adult patients with sustained polymorphic VT need immediate defibrillation. That's a class 1 recommendation.
Immediate. Even before trying meds like magnesium.
Meds like magnesium might help treat the underlying cause, maybe an electrolyte imbalance, but they should never delay shocking the patient. Electricity is the only thing that will terminate that dangerous rhythm right away.
Okay. Speaking of electricity, what about some of those newer, maybe more controversial techniques like double sequential defibrillation DSD or using those head-up CPR devices?
Good question. For DSD, using two defibrillators basically simultaneously, the guidelines are still pretty cautious. It's out there as a potential option if standard defibrillation isn't working for refractory VF, but routine use is not yet recommended. It's a CR2B, meaning it can be considered, but it's not standard practice. We still need more research to figure out exactly which patients benefit and the precise timing needed for that second shock.
Still needs more study. And head-up CPR.
Similar story for head of CPR devices, the ones that elevate the head and chest during compressions. The theory is interesting, potentially lowering pressure inside the head. But the current evidence, especially on actual survival outcomes, is just too limited. So, again, routine use is not recommended outside of formal clinical trials. This is a class 3. No benefit ruling for now. We need to be careful not to jump on complex new tech until the data really proves it helps patients.
Got it. Okay, let's move to the special circumstances section. Cardiac arrest during pregnancy. This has got to be one of the highest stakes scenarios imaginable.
It absolutely is. The time pressure is immense. You're trying to save 2 lives, and that pregnant uterus, especially later in pregnancy, can compress the major blood vessels, severely limiting blood flow back to the mother's heart. So if the top of the uterus, the fundus, is at or above the level of the belly button, 2 things are critical and immediate class 1 recommendations. Prioritize advanced airway management, and you must provide manual left lateral uterine displacement, basically pushing the uterus off the left side to relieve that vessel compression.
And there's a really strict time limit for delivery.
Yes, this is arguably the single most critical takeaway for this scenario. Resuscitative delivery, meaning an emergency C-section, needs to be complete by 5 minutes after the start of the cardiac arrest. That's a class 1 recommendation based on non-randomized studies and expert opinion.
Complete by 5 minutes. That's incredibly fast.
It has to be. If the mother's circulation hasn't returned by the 4-minute mark, the team needs to be actively preparing for or starting the C-section. Any further delay dramatically worsens the chances for both the mother and the baby due to lack of oxygen. It's an incredibly tight, crucial timeline.
Wow. Okay, what about patients with LVADs, those left ventricular assist devices? How do you even know if they're in cardiac arrest if they don't have a normal pulse?
That's the challenge. LVADs often provide continuous flow, so a palpable pulse might be weak or absent even when things are okay. To confirm arrest or severe hypoperfusion, rescuers need to look for other signs, like the patient being unresponsive, having cool, clammy, or bluish skin, cyanosis, maybe very poor capillary refill. Treatment then requires a dual focus. Start CPR immediately, but at the same time, have a second rescuer try to troubleshoot and restart the LVAD itself. Often, the LVAD stopping is what caused the arrest, so you need both CPR and attempts to restore the device function. That's a mix of class 1 and 2B recommendations.
Got it. And just quickly, anything new on hyperthermia or infectious risks during CPR?
For severe hyperthermia or heat stroke, rapid cooling is vital. The goal is at least 0.15 degrees Celsius per minute, and the guidelines recommend ice water immersion as the most effective way to achieve that CRR2A. Regarding infectious risk, like with COVID-19, while yes, chest compressions and airway stuff can generate aerosols, real-world data collected during the pandemic show that the risk of transmission, like SARS-CoV-2, is actually low if rescuers are consistently using appropriate personal protective equipment, PPE. That's a Class 1 recommendation, use your PPE, but don't hesitate to provide care.
Good to know. And finally, eCPR. Using external machines to circulate blood, is that becoming more mainstream?
It's definitely moving out of the purely experimental realm. eCPR extracorporeal CPR is now officially included as a part of the systems of care for certain highly selected patients, adults and children. The absolute key filter here is having a potentially reversible cause for the arrest. Think things like severe allergic reaction, anaphylaxis, accidental hypothermia, certain types of poisoning, situations where the underlying problem is treatable if you can just buy some time. In those cases, eCPR can be a bridge to recovery. It gets a CR2A recommendation for those selected cases. But if the cause is, say, end-stage irreversible heart failure, eCPR isn't appropriate. All right, so let's say we've successfully achieved ROSC, return of spontaneous circulation. The patient is now in the post-cardiac arrest care or PCAS phase, and honestly, what happens here is often what determines the long-term brain outcome. So the new guidelines really zero in on managing this phase carefully.
Okay, starting with temperature. Targeted temperature management, TTM. We know cooling or preventing fever is important. What's the latest on how long to do it?
Right. TTM is still strongly recommended for adults who remain unresponsive after ROSC. Keeping that temperature controlled, somewhere between 32 degrees Celsius and 37.5 degrees Celsius. The big update is on duration. Based on new evidence, the shortest recommended duration for keeping that temperature controlled is now 36 hours. That's a COR2A recommendation.
36 hours. Why that specific time frame?
It seems to be the sweet spot, balancing the potential benefits for neurological protection against the risks and potential complications that can come with keeping someone cooled or preventing fever for too long. It gives clinical teams a clear, evidence-based target for how long to maintain TTM.
Okay, 36 hours for TTM. What about figuring out why the arrest happened? What diagnostic tools are recommended right after ROSC?
First thing, absolutely mandatory, Class 1. Get a 12-lead EKG immediately. You need to look for underlying heart problems, like a heart attack, that might have caused the arrest. Beyond the EKG, other tools are considered reasonable, COR2B, things like point-of-care ultrasound, especially looking at the heart, echocardiography, maybe a CT scan. These can help find the cause, but also look for complications that might have happened during the resuscitation itself, like a punctured lung or internal bleeding.
Makes sense. Now let's talk about something really tough, neuroprognostication. Trying to predict the neurological outcome, how much brain damage there might be. This sounds incredibly complex and ethically charged. The guidelines seem to have a strong stance here.
They do. A very strong Class 1 recommendation. And it's crucial for providing compassionate, ethical care. The mandate is this. Healthcare teams must avoid using single pieces of information like just one finding on a neuro exam, or one biomarker result, or just one EEG reading at one specific moment to predict the patient's long-term outcome.
Avoid single data points. Why is that so critical?
Because relying on a single snapshot in time is just too risky. You might make the wrong call about withdrawing life support. The patient might still be affected by sedation or paralytics used during the arrest, or just the massive metabolic upheaval that happens right after. Accurate prediction requires looking at the whole picture, using multiple data points, tracked over time, often 72 hours or even longer. You need to integrate the clinical exams, repeated EEG results, maybe neuroimaging like MRI, and specific biomarkers. Only by combining all that information over an appropriate time frame can you get a reliable sense of the potential for recovery.
So it's about patience and using a multimodal approach.
Exactly. No single test tells the whole story right away.
And I noticed a really welcome addition in this section, something acknowledging the toll this takes on the staff.
Yes, finally. There's now a specific mention of healthcare professional burnout. Doing resuscitation work is incredibly stressful, emotionally draining. The guidelines now acknowledge this systemic problem and state that interventions aimed at addressing burnout, things like critical incident debriefings, peer support programs, access to mental health resources, may be beneficial. It's a COR2B recommendation, but it's an essential first step in recognizing and supporting the well-being of the responders themselves.
That's really important. Okay, last big section, education science, training people. The focus here seems to circle back strongly to those disparities we talked about earlier.
Absolutely. The mandate is clear and carries high priority. There are strong recommendations, Class 1 and 2A, to specifically focus and tailor lay rescuer CPR training to address those known disparities. This means actively designing programs that overcome the barriers faced by different racial and ethnic groups, by communities with lower socioeconomic status, or by people who face language barriers. It's about meeting people where they are, making training truly accessible, affordable, and culturally relevant. We can't just offer one-size-fits-all training anymore.
And what about kids? When should we start teaching CPR in schools?
The recommendation is strong, Class 1, that kids age 12 to 18 should definitely be trained in high-quality CPR. They generally have the physical ability and understanding to do it effectively. But interestingly, there's also a Class 1 recommendation to start training even younger kids, below age 12, maybe even as young as 4 to 7.
Really? 4-year-olds learning CPR?
Well, not effective compressions, obviously. But they can learn the basic concepts. Recognizing an emergency, knowing how to call for help, like 911, maybe even how to fetch an AED if one's nearby. The idea is that this early exposure builds familiarity and increases their willingness and confidence to act later on when they're physically capable, planting the seed early.
Makes sense. Okay, finally, the technology and training piece. This sounds like a key aha moment. We know feedback mannequins are good, but there's a big warning about virtual reality.
Yes, this is probably one of the most surprising and important findings in the education section. We already knew that those mannequins with real-time feedback, highly recommended, Class 1, Level A evidence. Why? Because just having an instructor watch you is actually pretty unreliable for judging if your compressions are deep enough or fast enough. The feedback devices are much better.
Okay, feedback mannequin's good. VR.
Here's the twist. While VR might be reasonable, COR2B, for teaching knowledge like learning the steps of an algorithm, the guidelines issue a strong warning. VR should not be used to teach CPR skills. Not for lay people, not for professionals. This is a Class 3 harm recommendation based on randomized controlled trial evidence.
Harm. Using VR for skills training could actually be harmful. How?
The research found that even with sophisticated VR setups, learners just didn't get the necessary physical haptic feedback. People trained using VR were actually worse at performing compressions correctly. Depth, recoil, compared to those trained on traditional mannequins with feedback.
So the lack of physical feel messes up the skill learning.
It's exactly. When you're learning a hands-on skill like CPR, getting that physical feedback right is absolutely crucial. Investing heavily in VR for skills training right now seems like it could actually lead to worse performance in a real emergency. It really reinforces the value of high-fidelity practice. Using things like gamified learning elements to keep people engaged, and especially techniques like rapid cycle deliberate practice for healthcare teams. That's where you practice, get immediate feedback, correct, practice again over and over until you really master the skill. That's what seems to work best for retention. Hashtag tag outro Waxa.
So what does this all mean when you put all these pieces together?
I think it means the 2025 guidelines fully embrace that Utstein formula we talked about at the beginning. It's this clear recognition that saving more lives isn't just about having better science. It's equally about high-quality, ongoing education, and maybe most critically, implementing these systems equitably, making sure they work for everyone, everywhere. We're really moving towards a vision of resuscitation that's more personalized, that's guided by real-time data and physiology, and that's delivered without these huge gaps based on where you live or who you are.
Okay. So the key takeaways for you, our listeners, seem pretty clear. For basic care, the lay rescuer is central. We need policy changes for naloxone access, strong guidance on compression-only CPR for adults, but absolutely conventional CPR with breaths for kids. For advanced care, think faster, more decisive action. Earlier epi and PALIS, starting high with cardioversion for unstable AFib, using physiology like DBP to guide pediatric CPR. And in those special cases like pregnancy, that 5-minute clock for C-section is incredibly critical.
And maybe the biggest underlying shift is in that post-arrest phase. The ethical imperative to move away from single data points for predicting brain outcome. Decisions about care need to be holistic, evidence-based, patient, and draw on multiple sources of information over time.
That's a really high bar for practice moving forward. Now, looking ahead, these guidelines always point to where more research is needed. What's the final, maybe provocative thought we should leave everyone with? What's a big unanswered question?
I think we absolutely have to tackle that huge survival gap we see between cities and rural areas. It's just not acceptable. So the provocative question for the future is, how can we really leverage mobile technology, things like delivery drones for AEDs or smarter dispatcher-linked apps in the most cost-effective way possible, specifically in these rural, often lower resource, high disparity areas? How do we use tech to bridge that gap, increase witnessed arrests, get CPR started faster, and get AEDs applied sooner? Solving that logistical and geographical challenge feels like the next major frontier if we want to truly improve survival for everyone.
Thank you for watching The Funnel Effect.